Alright, so obviously if you want to come to the review session again tomorrow, you're more than welcome. Thursday, 5 p.m. I think Nat, 11:40. Final exam is Wednesday, December 21st, 7:25 p.m. Ingram Hall. Come to B10 unless you have a McBurney's visa. Then you're going to be in room 22. You will probably get a few more emails saying the time and date because we always have people show up late or forget. And again, if you ask for an alternate final exam, you should have gotten an email back from me by now. If you did not get that email, you need to email me as soon as possible.
Do you know how long the exam will last?
It's going to be the same format as the first two exams, so 45 multiple choice questions. It shouldn't take the full 2 hours. Alright, so weight management. So we talked a little bit about body size and life expectancy. So being overweight is associated with tons of health risks, type 2 diabetes, heart disease, cancers, stroke. But on the other end of the spectrum, if you're underweight, it can really mess with your immune system just from being undernourished and getting that lack of nutrients. So weight management secrets. To manage your weight, obviously you need energy balance. I think in the past I had something up there about negative energy balance. That's good for weight loss, but so if you're just managing your weight, wanting to stay where you're at, you just want an energy balance. Energy intake equals your energy expenditure. And how do we do this? We're going to do it through lifestyle changes. So more exercise and good diet management. So there are three components of energy expenditure. Your basal metabolic rate. It's going to make up about 60 to 65% of your daily expenditure. It's hard to change, but you can change it through dieting and exercise. We'll get a little more into that later, but typically you want to change it through exercise rather than diet. And really what it boils down to is your speed of metabolism and the energy it takes for your body to function. Then you have thermic effect of food. This is going to be about 5 to 10%, and this is just going to come from energy used chewing, digesting food. And then the last component is physical activity, and this is going to make up the rest of your expenditure anywhere from 20 to 35%, and this is any voluntary activities that you do. So again, energy balance, trying to find a happy medium between intake and expenditure. So if you have a positive balance where you have more intake than energy you're expending, you're going to gain weight. If you have a negative balance, so less energy intake than you're expending, it's a good way to lose weight. Yep.
Sorry, where does resting metabolic rate fit into the components?
So it's pretty interchangeable with the basal metabolic rate. It's just slightly higher at rest, but really it's pretty much the same thing. We use those terms interchangeably. So the historical perspective, so intake of calories from 1900 to 1985, there was actually a decrease in intake of calories. However, from 1985 to the present, we've increased it back up. So, and then on the other end, expenditure of calories, it's just been a steady decrease the whole time. So what have we seen? There's been a correlation with the rise of overweight individuals to the point that 68% of the population is overweight, 35% are obese. And why do we care about this? Well, again, like I mentioned before, being overweight is associated with a bunch of health risks, type 2 diabetes, heart disease, cancers, strokes. And they've recently changed the overweight cutoff line. So it used to be a BMI of 27, it's now a BMI of 25. That was really just because they're seeing the same health risks at a BMI of 25 as they were at a BMI of 27. So again, with this increase of intake of calories and a decrease of expenditure of calories, we've seen a large increase in obesity rates and soon may become the #1 cause of death. But again, we also know that it's not just an adult issue. Rates are increasing for children as well. So what changes have been made? So energy in changes. 50% of the population are eating out. These are going to include high caloric meals. You have sugary beverages as well, sodas, pops, and the sizes of those are increasing. And And so there's really just no control of caloric density, especially when you eat out, and restaurants rarely share their caloric content, so it's hard to tell what exactly you're intaking. So I know he showed you guys the different size cups, back from like the really small Coke bottles. I did a little quick research. One of my parents really loves the half and half brisk lemonades, teas from Quick Trip, and they have huge drink sizes. The smallest starts at 22 ounces, 32 ounces for the next, 44, and then up to 52 ounces. That's 52 ounces is pretty much 2.5 bottles. Energy out changes. So obviously we have cars now, public transportation. We've really kind of worked out, decreased the amount of physical labor we do, drive-throughs as well. And so one way to get weight loss is through dieting. We know that there's a pretty small success rate, about 3% for that. Talked a little bit about set point as well, and the set point is just the optimal weight range at which the body can operate. And then dieting, and when it comes to your basal metabolic rate. So if you remember, dieting actually decreases your basal metabolic rate, and this is something we do not want to do because it's such a large component of energy expenditure. And really, what it does is it starts to break down your muscle mass, which is what actually uses the most energy. And then the weight loss curve. I know I've had a lot of questions on this. This is your weight loss curve. So you have the weight loss throughout the first 6 months. You kind of, bottom out there. And then through the next 18 months, again, you kind of lose focus, gain the weight back, and you're back up to that original weight within 2 years.
So why would dieting decrease the base metabolic rate?
So dieting decreases basal metabolic rate because dieting is going to actually start to break down your muscle mass if you just use dieting alone. And I'll get a little more into it in a slide or two here. So this low success rate for dieting usually comes from strategies such as excessive caloric restriction. Different ways you can do this are restrict your variety of food, decrease your meal frequency, and control the portion size. We know these are pretty hard to maintain, so the big thing we want to focus on is moderate restriction, something that you can maintain for a longer period of time, something that's easy for you to do, something that allows your body to adapt rather than just cutting half your calories right off the bat. So again, moderate restriction, again, we're focusing on a negative energy balance, but we want to maintain that BMR or even possibly increase it. So different ways to do this, increase your physical activity. Exercise is going to help build muscle mass, and that's going to actually push up your basal metabolic rate. And so again, modifications to diet and exercise together work best. Meal frequency, we talked about wanting to eat more meals per day. So 3 to 4 per day keeps the motor running. And then carbs are necessary. They're going to help spare protein, again, muscle mass. Foods to avoid, so high energy foods, fats, sugars, simple sugars especially. The body really struggles to regulate liquid sugars. And then whole milk as well is a little thing we touched on. So it's 4% fat, but that fat makes up about 50% of the calories you're getting from the milk. Oops. Again, alcohol, similar to liquid sugar, it's just hard to regulate what you're taking in, and that also empty calories. You're not getting any nutrients from alcohol. And so foods to eat. So fiber-rich foods, complex carbs, low proteins, low-fat dairy products. We talked a lot about that in the second unit. And then, so with regular exercise, you actually get to eat more. So you're building muscle mass through exercise. Your body's going to actually need more energy to function throughout the day. So actually, you get to eat more once you start exercising. So we talked a little bit about the differences between weight loss and weight control. So weight loss, we want to focus on aerobic exercise daily, 40 to 70% of your max, and 60 minutes. You can do this in smaller blocks of 10 minutes. And like Kelly mentioned today, really just want to strive for 30 minutes of moderate intensity of activity per day. And then weight control mode, you're going to want to do a mix of aerobic and weight training. 3 days aerobic, 2 days weights, 60 to 75% of your max, about 30 to 45 minutes per day. So back to that kind of the energy density. So same amount of calories each meal. You can see on the left, more fat food, lots of fats, lots of high energy density foods. And then on the left, you got your fruits, you got your vegetables, you got your low fat dairy products. You can see, I mean, it's at least twice the amount of food that you get to eat. So back to diet versus exercise and their effects on BMR or RMR. So the Donahue study looked at diet, and they cut their intake to 1,000 calories per day, and it actually decreased the RMR by 4.4%, and exercise, just moderate vigorous intensity, increased the RMR by 5%. So remember, BMR, RMR is the largest component of your energy expenditure. Anything you can do to increase it is going to help really with that energy balance. And then what type of weight is lost with each method? So Padlow study, a diet group lost about 20 pounds, exercise group about 26. However, the diet group lost 36% of their lean mass or their muscle mass and 64% fat, while the exercise only lost 5% of their lean mass and 95% fat. So again, muscle takes energy to function throughout the day, fat does not. Genetics and weight loss, so we know a lot of genes have been linked to obesity, and the Bouchard program looked at a diet program of losing about 1 pound per week and looked at sets of twins. So within a set of twins, they found similar rates of weight loss, but between sets of twins, it was different. The weight loss registry looked at people who lost, I think it was like 60 plus pounds and were able to keep it off, and found that really the keys were regular exercise and good dieting habits. And then BMI versus body composition. So BMI is your weight in kilograms divided by your height squared in meters. And remember that when you start exercising, you gain muscle. So maybe you're staying around a similar weight, but you're cutting out fat, gaining muscle. So BMI is not always the best thing to use, especially for athletes. Consider, linebackers or linemen on the football team. Pretty heavy guys, a lot of that is muscle, but according to the BMI, they'd probably be considered overweight. And then body composition, this is your percent body fat. So healthy amounts for males are between 8 and 19%. For females, 21 to 33% body fat. And should we use this as a starting point for an exercise program? Typically you don't want to. It's not going to take into account water retention, muscle gains, your medical history, and genetics. So really what it boils down to for weight loss considerations, make your goals small. You don't want to lose weight too fast either. That can be unhealthy. You have to take into account your genetics, any medical issues, hypertension, cholesterol, and your medical history. And typically, 1 to 2 pounds per week of weight loss, even as low as a quarter pound to a half a pound of weight loss. That way, something you can sustain, you develop good habits, your body's going to be able to adapt. Then we talked a little bit about the psychological components. And so with food intake, so if you restrict your calories, it's associated with increased psychological distress. And if you increase calories, or just caloric intake in general, is associated with feeling better. And we'll talk a little bit about emotional eating as well. So within studies done on athletes, they looked at caloric intake in swimmers and found that those that were restricting calories or not quite getting enough calories to make up what they had used throughout the day were having elevated distress, while those who were eating enough didn't have any psychological distress. And then they looked at anxiety changes in wrestlers. So looking at the group that had to lose weight, they found an increase in anxiety after 48 hours while losing weight. And then this was reversed after the weight loss period ended. The CDC looked at diet and exercise programs in non-athletic undergrad students and found that 20% of women and 21% of men were overweight, while 42% of women were dieting and only 17% of men were dieting. And then 63% of women and 42% of men were exercising. The Wisconsin study of athletes and non-athletes looked at athletes and non-athletes about 20 years down the road and found that those who were physically active gained less weight regardless of whether they had been an athlete or a non-athlete before, and looked at creeping obesity. So this is one gaining about a pound per year. And so 2-3 years out of college, I've gained 2 to 3 pounds, not a huge deal. 15-20 years down the road, you've gained 15 to 20 pounds, can be a little bit more problematic. So after college, obesity tends to become more common and problematic. Kelly touched on this today as well, but intake goes up and expenditure goes down after college. Food intake has been programmed into society. You get bagels at work, pizza at school functions, while physical activity has been programmed out. You've got escalators, public transportation, drive-thrus. So again, how do you beat the odds? Self-monitoring, make sure you're taking care of yourself, exercise, good diet management, and also take care of your mind, so stress management, which can be done through exercise. And again, make the changes slowly and let your body and brain adjust. We touched a little bit on the female athlete triad. The three things of this are energy deficiency, menstrual disturbances or amenorrhea, and bone loss or osteoporosis. CDC looked at risky eating behaviors in the college population and found that some of the top ones were anorexia, bulimia, binge eating disorder, and excessive caloric restriction. The Wilson study found that eating lunch was associated with a reduction in anxiety. And again, to avoid weight gain, the CDC recommends at least 60 minutes of moderate intensity physical activity. We've also looked at the Amish community and found that obviously they have high levels of purposeful physical activity. So the obesity and overweight rates are significantly less. 4% of the Amish community were obese compared to the 34-31% that we know, and then 26% compared to 65% for overweight. So taking care of the heart, talked a little bit about the emerging field, psychocardiology, and how they're looking at different things like personality types, anger and hostility, and depression. So when it comes to personality types, the type A, these are hard driving, competitive, workaholic types compared to type B, more go with the flow and laid back. And so they found that the survival rate was twice as great for type A's 20 years after a heart attack compared to type B's. They looked a little bit at anger and hostility and found that heart disease progression was more rapid in people who scored higher on hostility scales. And then survivors often reported that their heart attack was preceded by an anger-provoking event. When looking at depression, so the Cohen study found that depressed individuals were twice as likely to have a cardiovascular event compared to individuals without depression. And then depressed adults had a 31% higher rate of cardiovascular events. And so depression also led to an increase of risk of mortality from a heart attack. And the American Heart Association now recommends screening for depression in patients with heart disease. And then the Blumenthal study suggests exercise training and stress management training techniques because they found that there are reduced depression and improved markers of cardiovascular risk. So, prevalence of heart disease, 1 in 3 Americans, or about 80 million people have heart disease. There's been a general decline in deaths due to heart disease. This is going to be from medical advances. We have defibrillators, we have medications now that help. And 32% of deaths are premature, so deaths occurring at the age of 75 or under. So it's not technically an old age disease. So what are your treatment options? Prevention, exercise, good diet, medication or surgery, and rehabilitation. So some of the different types of heart disease. So congestive heart disease, this is the heart's function as a pump to deliver blood is inadequate to meet the body's needs. Congenital heart disease, it's a heart disease present at birth. Typically it's going to work itself out. And then coronary artery disease, this is a narrowing of the small blood vessels that supply oxygen and blood to the heart. And typically this can happen from atherosclerosis. So atherosclerosis is the degenerative changes in the arterial walls involving buildup or deposit of plaque. And we know that from looking at Korean War casualties that even at a young age you are susceptible to early onset atherosclerosis. And the main areas that this can have a major effect are the heart, like we mentioned, in the coronary arteries. That's going to lead to a heart attack. The neck, in the carotid arteries, which can lead to stroke. The legs, this we're going to see an intermittent claudication, which will lead to chronic leg pain. And then the kidneys, which will be seen in the renal arteries, and this can lead to kidney failure. And remember, heart disease is sometimes hard to see. A lot of the symptoms are actually asymptomatic, so we don't really know what's going on at the time. We'll talk a little bit about Jim Fix in a second. Angina or pectoral angina is chest pain. One way we can see heart disease is through an EKG, and typically that ST segment is going to be depressed compared to a normal EKG. And then talk about myocardial infarctions. These are just heart attacks, typically going to be caused by a thrombus or a blood clot. And we have major heart attacks and minor heart attacks. So major is going to be a larger attack in the upper branch of the artery. It's going to cause significant damage. A minor, you probably see that blockage in a smaller branch in the blood vessels and not quite as much damage from those. So the risk factors, talked about primary and secondary. So primary risk factors, they have to be significant, they have to have a direct impact, and they have to be modifiable. So exercise, sedentary behavior, alcohol consumption, smoking, all things you can change. Secondary, these are going to be non-modifiable. These are going to be your genetics, your age, your gender, stuff you really can't change. Medical history as well. Talked a little bit about dose-response relationships. So as the dosage increases, the response pattern is consistent. So the example, your top graph on the right there, the higher the total cholesterol, the greater risk of mortality from heart disease. So yes, you can see as your cholesterol goes up, greater chance of mortality from heart disease went up as well. And then synergism. So this, we kind of mentioned, there can be an exponential increase with each added risk factor. And so that's your bottom graph, and that is looking at the danger of a heart attack and stroke with a number of risk factors present. So there are no risk factors. That's the first column. I think it's like 77% chance of a heart attack, 66% chance of a stroke. Potentially, maybe not percentages, but with cigarettes, those jump. With cigarettes and cholesterol, pretty much doubles. And then with cigarettes, cholesterol, and high blood pressure, triples, even quadruples. at that point. Continue with taking care of the heart, talked a little bit about blood pressure. Blood pressure is important for circulation of the blood throughout the body, and it's going to increase during exercise. So systolic blood pressure is the blood pressure against the arterial walls when the heart contracts, and your diastolic is the blood pressure between heartbeats, and this is going to be a constant pressure. So normal blood pressure, 120 over 80 and under. Pre-hypertension, 130 over 85. Borderline hypertension is 140 over 90, and then essential hypertension is 160 over 95. So it's nice to know these figures. Obviously, if you're at the doctor's office getting a checkup, maybe you're sitting at 138 over 85. Technically don't have hypertension yet, but it's a good warning sign of knowing, hey, I need to do something to take care of this. So we talked about Jim Fix syndrome. Remember, a lot of stuff with heart disease can be asymptomatic, or you just don't know what's going on. This guy ran miles upon miles every day. One day they found him on the side of the road dead, and found that medical history, but he was predisposed to heart disease. He didn't know it at the time. Thought that what he was doing was enough. So again, checkups are important, and we'll get a little bit into that. I think blood pressure, get at least once a year. Cholesterol, every 5 years. So, activity in heart disease, talked about indirect support and found that exercise, we see fewer symptoms of heart disease and a better survival rate if you do have a heart attack. And then the direct support, studies that have actually looked at this, we know that through exercise you're going to get a larger, heavier, healthy heart, larger coronary arteries, and less plaque buildup in the arteries. Work of the heart is measured through cardiac output. This is your heart rate times stroke volume. So how many beats per minute times the amount of blood you're pumping with each beat. And some of the other exercise benefits we mentioned were improved myocardial circulation and metabolism, enhanced vascularization, increased glycogen stores, increased contractile properties of the heart. The blood's less likely to clot. It's also, body's going to have increased ability to dissolve clots should it happen. Exercise is going to alter your heart rate. Typically it's going to help decrease it, and decreased heart workload as well. So when the heart has to beat less to supply the body, becomes a lot more efficient. Getting into cholesterol, so the different types. So chylomicrons are lipoprotein particles that consist of triglycerides, phospholipids, cholesterol, and proteins. They're going to transport dietary lipids from the intestines to other locations in the body. We also have very low density lipoproteins, or VLDL. These are going to deliver endogenous triglycerides to the cell. Low density lipoproteins, or LDL, this is our bad cholesterol. It's going to carry certain lipids to certain cells in the arteries, and high levels of LDL cause buildup on the arterial walls. And then we have high density lipoproteins, or HDLs. This is a scavenger cholesterol, or this is our good cholesterol. It's going to pick up lipoproteins from cells and arteries that don't need it and transport to the liver for excretion. It's also going to remove cholesterol from the arteries. It's going to help protect against heart disease. So it's going to go through and kind of pick up the LDLs when it can. So levels of cholesterol. So we want total cholesterol to be under 200. Anything over 200 at risk for heart disease. LDL we want under 130. Again, anything over 130 is bad. And then HDL we want the good cholesterol. Anything over 40 is good. So through exercise, we can get an improved blood lipid profile, so decreased LDL, increased HDL. Like I mentioned before, get your cholesterol checked at least every 5 years. Unless you're predisposed, then I think it was every 3 years. We know that estrogen will decrease LDL and increase HDL as well for females. We don't necessarily have to eat cholesterol to have it in the body. The body can make it on its own. And we're going to have high levels of cholesterol in saturated fats and oils. Talked a little bit about omega-6s and omega-3 fats. So omega-6 is going to help lower cholesterol. Omega-3s are great for help healing after a heart attack. And it's also going to help reduce blood pressure response and thin the blood. And then soluble fiber is important in the diet again because it's going to help increase excretion of cholesterol. Hypertension and heart disease. So high blood pressure is going to make the arteries more vulnerable. There's a strong relationship with sodium. So the DASH study looked at sodium intake, and so the control group had 4 servings of fruits and vegetables, half a serving of milk, and potassium, magnesium, and calcium levels at the 25th percentile. And then they had a fruit and vegetable group, so increased fruits and veggies, no intake of dairy, and potassium and magnesium at the 75th percentile of intake. And then a combo group that had even more fruits and veggies, dairy products, and again, potassium, magnesium, and calcium. And found that after 8 weeks, those fruit and veggie groups and the combo group were restricting sodium intake as well. So after 8 weeks, they found that fruit and veggie group blood pressure went down from 140/90 to 133/87. So going down from borderline hypertension to pre-hypertension. And then the combo group went down from 140/90 to 129/84, so almost back to normal blood pressure. So again, there's a high intake of sodium is associated with high blood pressure. However, if we can limit our intake of high blood pressure or of sodium and increase our potassium, magnesium, and calcium intake, we can help lower the blood pressure. So sodium, it's added to food, fast food, salt at the table, processed. Very few foods actually have sodium in them naturally. It's just, our country is pretty obsessed with salt these days, so people just tend to dump it on. You're going to get potassium from fruits and vegetables, magnesium as well, and calcium from milk and certain vegetables as well. Then we got into taking care of the bones. So we have osteoblasts and osteoclasts. Osteoblasts build bone by laying down matrix and mineral. It's going to take part in bone repair and remodeling. And then osteoclasts dissolve the bone, release calcium into the bloodstream. This is really going to happen when your blood calcium levels are low. Remember that calcium is needed for a lot of bodily functions. We need it for muscles to contract. So calcium is very heavily regulated within the body. Estrogen and vitamin D. Estrogen is going to help try and protect calcium, keep it in the body, and vitamin D is needed to help get calcium into the bloodstream. We talked a little bit about the negative effects of caffeine and alcohol intake. So caffeine and alcohol are diuretics, and this is just going to kind of speed the rate of transit of those of caffeine and alcohol through the body. So any calcium that was consumed with it kind of goes right along with it. Protein intake. So if you intake a lot of protein, higher than you should, the blood becomes very acidic, and calcium acts as a buffer to that acidic amino group that's attached to protein. And phosphorus intake, high amounts of phosphorus, it's going to bind to calcium. You're going to lose it through fecal loss. And smoking, like I mentioned before, estrogen wants to protect calcium levels. It's going to decrease production of estrogen. Osteoporosis and osteoarthritis. So osteoporosis, a lot of different risk factors. You have modifiable risk factors and non-modifiable risk factors. So your modifiable ones include diet, surgical procedures and medications can play a role in bone loss, and smoking, alcohol, and inactivity as well. Some of the non-modifiable, women are more susceptible to osteoporosis. Age, race, family history, body frame size plays a role, your hormone levels, and thyroid problems. So one way to combat this is through weight-bearing exercise, and they've looked at astronauts and people just taking part in bed rest and found that there can be as high as 1% loss of bone mineral density per day. So back to the weight-bearing exercise, they looked at postmenopausal women, and so you can see the pink line is the control group, no exercise, and the blue line is the exercise group. So for 13 weeks they exercised and found that there was an increase in bone mineral density, and once they stopped that exercise, it rocketed down. And then osteoarthritis, so just your basic wear and tear. It's going to start, it's going to lead to a breakdown in bone. Body's going to want to remodel that bone. You're going to get decreased shock absorption, which is going to lead to increased stress on articular cartilage, and eventually that cartilage is going to break down. So this is going to lead to joint degeneration. This is a pretty classic age-related disease, but there are other individuals at risk as well. Overweight individuals, collision sports, you mentioned soccer players' necks being a big one, and then children even competing early in collision sports are highly susceptible to osteoarthritis. That's all I have. He's going to send out review questions for today's stuff. I will update these slides with that information as well. I did my best to answer as many of the review questions as possible. So once those come out,